across our college. And so this year, or this semester, we are starting our first one with Dr. Baker, Dr. Lockwood, and Dr. Bayshore. And then we have 2 others coming up. And so if you needed a schedule, it's out there by the sign-in. If you haven't signed in, please do so. But the schedule shows that February 13th, which is also a Friday, they're always on Fridays, Dr. Esposito is going to be here to talk about health and wellness in children with intellectual disabilities. And then Dr. Lund, who's here today, is going to talk about responsiveness, maternal input on responsiveness and word learning in children with and without cochlear implants. So great series of speakers this year. Love for you to come back out. Students, don't feel like you have to have the invite. Please come out and be part of this if you want to be. And then a couple of announcements. One is that April 16th, we have our Student Research Symposium. All that information is online already, ready to go. So if you have someone who's going to be presenting, make sure you get that information off the web from Harris Research. If you are doing a presentation and you need more information from me, please feel free to email me about that as well. And then as far as the food, we've got plenty of it. Please go back. There's like whole things of food. So if you need dinner tonight or for the weekend, take it, please. All right. So without further ado, I'm going to have Dr. Baker and Dr. Lockwood come up and talk to you today. As you can see up here on the screen, this is a very special topic today with pancreatic cancer, since we just lost our dean to that disease December 12th. So without further ado, please come on up. Thank you.
So Dr. Bayshore is teaching clinicals today, so she could not be here with us. And Dr. Lockwood and I are presenting for you. This is really still preliminary in a lot of ways. When you do qualitative research, you often have very rich data that you can wallow in a long time. And so while we have done our best to really paint a picture for you of the main things that our informants talked about, there's still some other information there that we want to go back and mine. And so when this finally hopefully is disseminated in publication, you'll probably see some additional information. So I'm the primary investigator for this study. It started while I was the full-time nurse researcher at Presby Dallas for Kathleen practices. And I'm a gastroenterology endoscopy nurse, and we often work with pancreatic cancer patients on the front end to diagnose them. Or if they have obstruction, we often will go in and relieve some of that obstruction. So I cared for a lot of those patients. Also, early in my practice, I was an ICU nurse and surgical ICU, and we used to care for those patients after they had a Whipple procedure, which is when you're kind of rerouting everything and trying to give them some relief. Sometimes it's curative and sometimes it's not. But back when I was young and working in SICU, those patients did not do well. And so usually when we knew we had a Whipple procedure coming in, we knew that it was going to be a really complex patient and that the outcomes probably would not be favorable. And so for both of those reasons, I was at Presby one day having lunch with a nursing college, oncology nurse, and she started talking about the support group that she ran, and lo and behold, it was for pancreatic cancer survivors. And I was like stunned, and I'm like, what do you mean pancreatic cancer survivors? Because my experience was they didn't really do very well. And so as we began to talk, it was very exciting for me to understand that now we've made progress and those patients do much, much better in terms of recovery. She had the support group going, and as we talked, I began to question, I'm a gastroenterology endoscopy nurse, and I'm not seeing much in the literature about pancreatic cancer survivors. And so I went and looked, and sure enough, there was absolutely nothing. And in fact, I still can't find anything in the Survivorship. And so I decided to work with my colleague Linda and to see if her support group would be interested in talking to me as a researcher about primarily what we as healthcare providers need to know and understand, and also for other pancreatic cancer survivors and their families to be able to know what to expect. So our formal purpose was to explore the quality of life experiences of pancreatic cancer survivors using qualitative methods. And we wanted to understand what life as a survivor is like when you've survived pancreatic cancer, how the cancer affects their life. And we wanted to know that just so that we could provide accurate information to other patients who were trying to make decisions about their care. Understand what was important to them as they went through this experience so that as both researchers and healthcare providers, we could really be accurately assessing their quality of life based on what they said was important to them. And then understanding their needs for living with a past diagnosis of pancreatic cancer. And so I collected this data while I was at Presby Dallas, and then not long after the study started, I ended up coming to TCU. And so Dr. Lockwood's specialty area is oncology. And as I said, the oncology piece is not my background. And so she very graciously became involved. And then she does work both with patients going through cancer as well as the survivor side. And then Dr. Lisa Bayshore, who came to join our faculty, that is really her area of expertise and focus. And so that's how the three of us came together to work on this study. So for this portion of the study, we did 6 pretty in-depth interviews. And I want to acknowledge I had 2 graduate students from the University of Texas at Arlington, where I previously had taught, that when I left to go to Presby, they came and wanted to do their research intensive with me. And so they actually conducted the interviews and were very engaged with that process. So we had 6 informants, 3 men and 3 women. So we sort of have a balanced perspective gender-wise. And interestingly enough, as we started this process, the family was upset that we were not asking them to be part of the study. So I had to go back to the IRB and get permission to actually include family members. So we also had 5 family members. Their information is not reflected here, but we will be analyzing their data and making some comparisons about that. So we went through that local support group that still meets over at Presby Dallas. And then in doing the interpretation, I'm very much what we call a mixed methods kind of researcher. So I like to use both quantitative and qualitative investigation so that I really understand. And usually I'm using qualitative to explain to me what that quantitative numbers and scores mean. And so I very often in that kind of approach have used Margaret Sandolowski's approach of using what she calls descriptive analysis. And you really are looking at themes. And so I have found as a clinician, I like that quick and dirty. So I don't tend to be a purist when I do qualitative research and do like grounded theory or ethnography or those other kinds of approaches. I like to go in and look and see what are the things that are emerging here and what's the so what information that as a practitioner I need to know in order to understand and care for my patients. And so that's why she used her approach, thematic interpretation. So Dr. Lockwood's going to kind of paint a picture for you, just a quick reminder of what pancreatic cancer is like.
So like Dr. Baker said, I sort of bring the perspective of the oncology nurse. I've been in oncology for 30-something years. And so we felt like it was important to give you all some background about pancreatic cancer. So the figures for 2014, 2015 are that there's about 46,000 people who will develop pancreatic cancer. Of those, 39,000 will die from pancreatic cancer. So you see that the survival rate for pancreatic cancer really is pretty low. And we oftentimes will look at numbers, 1 in 3 women actually will develop develop some sort of cancer, and 1 in 2 men will develop some sort of cancer. Well, for pancreatic cancer, it's 1 in 76 people will actually develop pancreatic cancer. It is actually the 4th leading cause of cancer deaths. When you look at all cancers, it is the 4th leading cause of cancer death. And we really don't know what causes pancreatic cancer. There's a lot of ideas, but we don't really understand what might be the primary cause for pancreatic cancer. If you go back and think about where the pancreas is, I sort of tried to give you a picture, which you may or may not be able to see, but it is located right there where your gallbladder, the bile duct, liver, it's all sort of stuck right in there, and that's part of why it is oftentimes hard to diagnose at an early stage, because it's oftentimes hidden by lots of other abdominal organs. So the risk factors for pancreatic cancer are family history. If you've had somebody else in your family that's had pancreatic cancer, you have an increased risk. If you smoke cigarettes, you have an increased risk. Obesity and diabetes can increase your risk as well for pancreatic cancer, as well as if you're someone who has had a history of chronic pancreatitis. So, like when I talk with students, I say these are just things that increase your risk. It doesn't mean that you're going to get pancreatic cancer, but they are things that would increase your risk. The prognosis for someone with pancreatic cancer is definitely influenced by where the pancreatic cancer is located, when it's diagnosed, whether it's in the head of the pancreas or if it's in the body or the tail of the pancreas, and then also if it can be localized and removed when it's diagnosed, and if it can be totally resected and how many nodes are involved when it's diagnosed. The 5-year survival rate, if it is localized and if it can be completely resected, is really only 18 to 24%, even if that is what we're able to do, is really localize it and completely resect it. And in most cases, that only accounts for 20% of people who are diagnosed with pancreatic cancer. And so this is one of those cancers that we all know has a very low survival rate. And it's a group of patients that we really want to try to learn more about. It's a cancer we want to try and do more research in, so that we can learn more about how can we diagnose it earlier and how can we figure out what causes someone to develop pancreatic cancer. There are no noticeable signs and symptoms of it early on, and usually when someone is diagnosed with it, it is advanced. The signs and symptoms are reflected by where it's growing. So they'll have GI symptoms, and that's because of the growth of it around the abdominal organs. They'll have abdominal pain, and that's usually what's experienced by 80% of people who are diagnosed with the pancreatic cancer. They'll have bloating, and they'll have something that's called early satiety, and that means that they get full faster when they eat. So you or I might eat a meal like we just ate, that we would typically eat very, not have any problem, and we just eat it like we normally do, but we begin to notice that that normal sized meal that we eat, all of a sudden, we get fuller faster, and that's abnormal. So that's that early satiety. They'll have nausea, and then they may have diarrhea, and they might notice that the stools or bowel movements are a paler color than normal. And that's reflective of the growth of that tumor around their abdominal organs. Then they'll have more global body symptoms, and they'll have weight loss, the malaise, they'll have loss of appetite, and then they may develop diabetes, and or they may just notice that their blood sugars are becoming abnormal. They may not develop full-blown diabetes, but they may notice that they're having elevated blood sugars. They may also have skin symptoms. That's because there is a blockage of the bile duct as that tumor may begin to grow. And there's a collection of bile in the blood. And so they may become jaundiced or they may develop itching because of the skin symptoms from the tumor growth. The way that we typically treat pancreatic cancer is really very simple because there's really not many options. It's either surgery or it's palliation, really. Because we don't have any good chemotherapy that treats it. And so if we can't surgically remove it, then it's what is called palliative care. And palliative care is not the same thing as hospice. Palliative care is treatment that we give to someone who has a life-limiting illness. So, pancreatic cancer is resistant to chemotherapeutic drugs. So surgery is the primary way that we would try to treat it if we know that we could remove the lion's share or the largest majority of that cancer. But very rarely can we do that. So it's only, as I have on here, 10% of cases. So as Kathy mentioned, there's the Whipple procedure, but when we do that, we're removing the head of the pancreas, removing parts of the stomach, and we're removing parts of the small intestine, and we're reconnecting everything. It's a very major surgery, and it's done very rarely. So there are 2 chemotherapeutic drugs that we're trying with patients to try and see if they work in certain patients, but not always. And then the only other option besides trying to manage pain and trying to manage some of the side effects from the pancreatic cancer is to put patients on clinical trials, which we know with our dean, we tried some chemotherapy with her, but then she also was put on a clinical trial. So there really isn't many options with pancreatic cancer. So there's the background, and then we'll talk about what we did with the study.
So when you do qualitative research and you're using interviews, you usually have some focused questions. You try and make them open-ended if you really are trying to get the experience. Or you have focused questions because you know there's very specific information that you're after. So I tried to design the questions so that we got a little bit of both. So a big global question, how has cancer affected your life? And then how has participating in the support group affected your life? Because I wanted to find out if that was helpful for this particular type of cancer patient or not. You saw that the prognosis is not very good. And so it could be that talking and meeting together actually makes it worse instead of better. And then what advice would you give to healthcare providers so that we can know what we need to be sensitive to and what we in fact should be passing on to other folks that are dealing with this? And then what advice would you give to family and friends? I told you that the data was very, very rich. And one of the other things that came out that we didn't specifically ask the question for, and that I'm not presenting today, that they had information that was directed at other pancreatic cancer patients. And so that would be sort of another category that we add, even though we didn't specifically ask that question. So how has cancer affected you? What we saw over and over is that it redefines who you are. And in particular, one of the informants said, well, to a certain extent, it redefines who you are. All of your friends look at you as a pancreatic cancer survivor, regardless of what your background is, what your accomplishments in the industry, your accomplishments as a father and a patient. And so I thought that was very profound because we do. That's our job as healthcare providers, and we're often thinking about their diagnosis and what we need to do. We forget to see them first as a patient that brings, who they are to us to care for them. So specifically, they talked about all different aspects of a holistic being. So physically, they talked about all the side effects that go along both with having that diagnosis and even with going through treatment. So weight gain, fatigue, nausea, pain, diabetes, constipation. There were others but these were the ones that very often people kept talking about. This particular quote, I got hit by a cement truck. I was nauseous, I was exhausted. They talked about how you could never quite get ahead of that. Psychologically, they talked about, we asked them specifically if they saw themselves as a survivor or a patient. And I think we had 3 that said they saw themselves as a survivor. One who said, well, I think I really see myself as a patient. One who said both. And then one who later in conversations and talking about support group kept talking about pancreatic cancer victims. And so I knew that there was some aspect of that was important to her. They talked about how all the time recurrence is possible and that's on your mind, and that they had to modify a lot of their plans for life. And just the normal things that they did had to be modified. Everything is focused in on the now, and so I'm trying to do more of that because I don't know what's going to happen tomorrow. Some of this is scary. You start reading statistics that you don't want to read. It's just constantly on my mind. You never know how long it will last or what kind of complications you might have, so it sort of hangs over you all the time. They talked about economically impact of that, because several people talked about, I don't know how people do this without insurance, because even with insurance, it's financially devastating. Socially, one person in particular kept talking about how they used to love to travel and see extended family, and so both that being with family and the travel part, she had to give up because she could not tolerate because of the exhaustion and the recovery. And then spiritually, people talked about how they have fear, they question why me, a lot of underlying hope and optimism in this particular group of 6 informants. It's something that nobody ever wants to hear, and it's always a tremendous amount of fear and a lot of why me goes on. You think about this stuff and you try and come to terms with it, but it becomes your life. I'm fortunate that my wife works full-time for a large company that has health insurance, because otherwise, I don't know how you do all this stuff. The cost of everything is crazy money. It's just out of this world. Another thing, as we were talking with them about how cancer is affecting them, we saw a lot of how their life becomes very intentional now. And so someone talked about getting back, they were trying to get it back to the way it was before, and that's what their goal was. Another just said, let's go, let's just move forward and deal with this and take it as it comes. Another said, I'm going to live it my way, that they were going to make decisions about their treatment and how they responded to this. Several of them talked about one day at a time. And then they talked a lot about just having now to focus on themselves and trying to stay well and adjust their lifestyle. I've tried to restrict the impact that it has on my life to the time period of having to have treatment and having to have recovery. I'm trying to limit the impact so it's not forever in my case. We wasn't thinking about 2 years down the road and what it was going to be like. We just tried to do one day at a time. So, Dr. Lockwood, can you talk a little bit about the support group?
So one of the things that we also want to talk to them about, as Kathy said, was talking about what effect did participating in the support group have. Because a lot of people have different opinions about, is it valuable or not to participate in the support group. So there was a real dichotomy that they had, these informants had about participating. Some felt like it was giving back versus getting. Some felt like it was inspirational versus the negativity. There was some value that some felt of participating in the support group that changed over time, that it was driven by changes in the experience that some of the informants had over time. So there were some pros that some of them felt. There was a camaraderie of meeting together, being able to share experiences. it provided some encouragement. They were able to develop some goals and some perseverance by being able to meet together. They were able to share ideas, and they actually got resources from each other by being able to, say, well, I, have this resource. And when they were talking about the money that it was costing, to be able to, give some ideas about where they were getting the resources. Hope, being able to get hope from each other was really, really important. So they saw that as some of the pros for participating in the support group. Of course, there were cons. Survivor guilt is a real big one because some of them that were living longer. The other thing being that they knew others that had died, and they felt like they were still alive, and yet they were still here in this group. Surgical versus non-surgical. Some of them had surgery, some of them hadn't, and so those differences. Some of the resources that they became aware of, that everybody was sharing, seemed sort of overwhelming by participating in this group. And of course, there's always somebody that's going to dominate the conversation. That some people weren't always able to share and participate, get their questions answered, because there was somebody that's always going to be dominating. Focusing on the negative was not always necessarily helpful. So some of the quotes were, I like talking to those people. There's something to be said for someone who has really undergone what you're going through. The more people you talk to like that, the more you think, well, yeah, I can do this. It helps me to help them, and it helps them to feel like they are helping me. That's another quote. I got so much out of the sharing. I can learn from them, and there are things that I like to give to them that will help them out. So there's some of the quotes that we got. Just to fellowship with other people that have the same problems, it's reassuring. It's nice to talk to people and share ideas and share things. My perspective on this thing is just hanging in there as long as physically possible, because every day they are doing more research on all these things, and you can never tell when the next day they are going to get the silver bullet that takes care of it, and you just have to be there for the silver bullet. So you got to just keep going, doing whatever they say to do to stay in the game. So, yeah, that's you now.
Yeah, and the person that was talking about the silver bullet was sharing that was their message when they were going to support group, was telling people to hang in there. All right, so for healthcare providers, this was really very evident, and it's not like they went on and on and on. It was just so much their unified message about how much influence that we have, that healthcare providers set the tone for things. So what you do and how you say it, and even the slightest kind of inferences, mean even more than you probably intend for it to mean. They're really taking their cues from their healthcare providers. And so they want you to be positive and to offer hope. So they talked about listening and how critical that was. They were very distressed because you know how as patients go through the healthcare system, there's multiple people. We have all these people that are doing all different things, and patients expect us all to be on the same page, and that is not how it unfolds, and yet that's the expectation. So they were frustrated when people didn't tell them about the support group at the different points of contact that they had. In the healthcare provider's office, in the hospital, the oncology nurses, in the outpatient centers where they were getting treatment. They were very frustrated by that. Many of them talked about how humor helped them to sort of come back down to a positive, smiling, holistic approach. This group in particular really was interested in nutrition and in alternative therapies, and that came out very, very heavily. And so that's one of those areas we're going to dig down a little bit more to look at. And they wanted their healthcare providers to at least be familiar enough and acknowledge that alternative therapies might be beneficial to them. that working as a team to coordinate care, that was really, really important. They gave examples of when they saw that and when they did not. And it was very profound in how they saw it and it impacted them. They always want advocating for the patient and nurses that are in the room. That was one of the things that one gave a very poignant example of how the nurse was really an advocate and went into the physician and got what that patient needed. And then that connecting, the relational piece is really, really important to them. Communication was another great big area that we saw, and they kept emphasizing how important it was that they wanted you to be truthful. And so you've got to learn how to balance that being truthful with that wanting us to be positive and offer hope as well. So what they said is we want to know both the positive and the negative. And one person shared with how because they were honest with her, the nurses and the physicians, when she was diagnosed, she happened to be in the hospital, it helped her to seek treatment and to make that decision faster. And she felt like that affected her outcome. And so that's why sharing the full picture was important, because she thought she would have procrastinated a bit if she had not known the seriousness. So complete information, you can be sympathetic but factual at the same time, and then always convey hope. And they gave examples that kind of helps you understand hope isn't that you're going to recover or that you're going to have cure. Hope can also be that just you're going to have more longevity or that you're going to have a peaceful death. And so, they may transition all the way through that. They may start out hoping that they're going to be the one that has cure. And then they begin to realize that's not going to happen, and they may choose longevity, they may not. And then I think all of them certainly want to hold out hope for a peaceful death whenever that might come to them. Different nurses didn't know the regimens for those enzymes and Reglan. I would get nurses that would argue with me about the regimen, that it wasn't when you were supposed to take them. Well, in healthcare systems, often it's very prescriptive about, it's written exactly when you're supposed to give those medications. So we have to learn how to be able to go and advocate and just say, hey, pharmacist, or hey, physician, this is when the patient usually takes it. They really, really, that is meaningful to them to stay on that same schedule. Do you think we can make that happen? Instead of just being flippant about, well, sorry, we give it at this, and this time, and that's the way it's going to be. By and large, I felt like the nurses were caring, good providers, and that goes a long way if you've got the feeling that a nurse is trying hard and has your interest at heart. I do appreciate nurses that will consider my input. Professionalism and confidence with an even disposition. That's the magical combination that makes you feel confident that you're in the right spot. The radiation technicians are some outstanding people. They were always upbeat. They were always friendly. We were always telling jokes with each other. They were fun people to work with. The oncology nurses are very special people. Brooke is the oncologist nurse I just love. I think she's a wonderful, upbeat, always caring, always had answers for things. If you tell her you're having nausea with this particular cancer drug, or fever or flu-like symptoms from this other cancer drug, she knows exactly what treatment you need. She will go back and talk to the doctor to get a prescription for something you can take to offset that. And they really, that came out over and over, they really admire people who seem to know how they can make them better. They all work with the utmost of professionalism, really seem to know exactly what they're doing. Every comment that they make is positive, or they tell me more about that, and we can get something to work. Even the pharmacist has been very, very beneficial to me, sympathizing with what's going on and then being very explicit in her telling me the best way to use these drugs, and that's been very helpful. I want to know the truth. I don't want you glossing it over. This one I think is very powerful. There was a friendly smile, the smile of, I know why you're here, you know why you're here, we're going to do this as smooth as possible. And then for family and friends, they talked about learning how to support, but then also respect that individual's choices. And so for the survivor, that patient that's going through it, it's very personal. I mean, it affects them in ways that maybe you or I would not understand how it's affected them. And so recognizing that their personal experience may be very different from yours and how you would handle it. Don't pressure them. Allow the patient to advocate for themselves instead of advocating for. And again, for those of us that are healthcare professionals in the room, because we're in an advocacy role all the time, when it's our own family, it's hard for us to stop doing the advocacy thing. And even as we did these interviews, there would often be a spouse that would pipe up and start, answering the question instead of allowing that informant to do it. And again, those issues of some people are going to pick longevity and some people are going to pick quality of life, and those aren't always the same thing. And as family and friends, acknowledge that. And it's okay to say, that's not, I wish that wasn't, but I understand and I support you, and it's okay. Family members wanted me to use the most aggressive treatment. They would have felt disappointed if I had gone through the surgery and not taken the most aggressive treatment after surgery. So again, sort of that, that pressure to do that. I don't know if guilt is the right word, but I feel like I ought to be providing more for the family. So here's someone that even while they're going through this, their worry is that they're not doing what they need to be doing for the family. So support was big. They often used we and partnership and talked about it as if it's not just happening to them. So there is recognition of that. If it was personal, they recognize how it's affecting the people that love them. They talked about trying to stay as normal as you can, have a positive attitude, take care of business, and find a support group that not only supports that cancer survivor, but that also provides support for the family. And this particular support group was that way. So both family and patients came, and the times that I was there, everyone would start out together and have conversations, but you'd always see sort of that natural split that would happen when we were doing refreshments and things. Family would talk to family, patients would talk to patients. And so some of that natural support of knowing each other is going through different things happening. We shared it with our adult Sunday school class and the staff at our church. There was a prayer that was being made for us, and I felt the power of that prayer, that it helped to share that burden. It helped me feel like we had people supporting us and my family. I can't imagine undertaking recovery without that kind of sharing with friends and relatives and the support that we had from all of our friends and relatives. This one is cute. It has dramatically changed my relationships with my family, and that I have a lot more patience with their crap. So our early takeaways from this is that survivorship of cancer does touch every aspect of your life, and it changes you. By virtue of that diagnosis, no matter what treatment you choose or don't choose, it changes you. Support groups do have a very positive impact on pancreatic cancer survivors, but there are some negatives and there are some shortcomings. And I think as healthcare providers, we have to be aware of that so we can be watching for that and then helping our patients be able to talk about that, or the family members, and to work through that. It came out, again, how very influential we are, and that often we're not sensitized to that. We don't really recognize the impact that we have. And support from family and friends is important, but it's difficult and it can be tricky because that survivor is going through so many different things that they're dealing with. So our next steps are that we're going to continue to do the analysis. Dr. Bayshore in particular, once we really feel like, Dr. Lockwood and I feel like we've pretty much mined everything that's meaningful out of that data. Because of her expertise in survivorship, she's going to then look at the data to see if it rings true with her expertise and all the patients that she has worked with. We also have that family data. from those 5 that we're going to look at and see what they have to say and share that information, and then look to see how things might be similar or different between those groups. We actually have a head and neck cancer study in progress. This particular study was actually funded by Sigma Theta Tau, the UT Arlington chapter, and now the head and neck cancer study is funded by our Sigma Theta Tau chapter here at TCU. And so we are hoping to begin data collection on that soon. Our long-term hope is that as we look at survivorship in different types of cancer survivors, then again, we could look to see what seems to ring true across all these different survivors and what things might be unique to certain cancer survivors with a particular history. So we think that we hopefully will be able to do sort of a systematic analysis across all of these studies. And then, of course, disseminating findings. And so we want to be sure that not only we talk to each other as healthcare providers, but that we really make things available so that newly diagnosed patients can understand what they might expect, to see what's normal in terms of what they're feeling or struggling with, and the same thing for their family and friends. This I wanted to end with is just why this work matters, and one of the reasons why I love doing qualitative research. I guess I'm glad that somebody has got funding to do this. I'm glad that somebody cares enough to put together this kind of research, and I hope that the findings from this will help other people. I feel like I've got a story to tell, and I'm glad that somebody came to record my message and my story and cares enough to put together this kind of study. So, you know, even as we do research, it can be very powerful for people, and that's one of the reasons I love qualitative, is it's often very therapeutic for people to be able to talk and to share, and to know that someone wants to know what is your story and what difference can it make for other people. So, Dr. Lockwood and I are happy to answer any questions that you might have. That's one of my favorite end of lecture kind of stories. It says, how many times have you thought, if I just close my eyes, this problem will go away? So, any questions, comments? Yes, ma'am.
My question is, what makes them a survivor? Is there a time limit? I mean, you survive so long, or are they diagnosed and cancer-free?
I think you would have to ask them what they consider a survivor. Susie, if you have a different notion, but
I have the definition by the NCI is that you're always a survivor. Now, I think that people make their own definition. I think that would be an interesting question to ask cancer survivors. But the National Cancer Institute and what most funding agencies consider a survivor is you're a survivor from the day you're diagnosed. And that from that point on, you're always a survivor.
But you know, when we didn't ask the question the way you just asked it. But remember how most of them said they saw themselves as survivors, and one said still as a patient. And I don't know if that's because he was still going through treatment, or if he had a certain point in time in his mind, or so that's a really interesting, an important question.
Also wonder, along those lines, you know, they say that they check them every however many months for like 5 years, and then after that, they don't check them anymore except through the regular doctor, because they say that at that point, they're past the danger stages in pancreatic and bladder and others, but with those cancers. So I'm wondering if sometimes that may have something to do with the definition as well. Do they go from survivorship to thinking that, they're in a different realm? I don't know.
They might consider this.
That 5 years seems to be the critical point.
there kind of an average length of time that they have been without treatment, or?
This group, there actually was someone in that group that was 10 years out, which blew my mind. There were others that died not long after you had them. And again, as they said, some that had surgery and some who had not. And usually the ones who had not was because they were not candidates. Yeah.
So I'm an endoscopy nurse, as you were, and we have the privilege of seeing patients sometimes at their diagnosis, and they get the information, and typically an endoscopy patient is with you only about 30, 45 minutes after their procedure, and they just continue with this information, and as you said, Dr. Weyer's reflections matter, and you know, we try to treat them respectfully and what have you, but in the fast-paced world that our department runs, and I've always wondered how do we balance that with this shock or this confirmation they just received, because we bring the pathologists, we take their tissue, and we usually tell them back in yay or nay, and if they're okay with the surgery, and then we shut them up.
Yeah. Well, so one of the things I used to try to do, and again, you know, life is different now in practice, but I used to try and go back within 24 to 48 hours if they were inpatients, just to go back and just see how they were doing, sort of that. They're not always inpatients anymore, and they could be outpatient.
And they, I mean, they're not all of them, I mean, occasionally they turn into patients, or the surgeon may come see them while they're there, just depends on what you're doing. But, I mean, some of them are 20, 30.
Yeah, I was going to say, we're seeing younger patients now with pancreatic cancer, where it used to be common that you were 50 or older, and now,
I mean, I like to get their story, why are you doing your procedure, and, oh, I looked at the ER, and I got scared, why did you do that? You know, why did you do that? Well, I was hurting, and they're just, you know, I've been doing that, I've been there, they didn't really, it wasn't supposed to be this, but they found this,
and usually, Dr. Lockwood talked about that. Usually if we find pancreatic cancer early, it's not that we were looking for it. It's usually that we're just trying to rule out other things, and it shows up on like an MRI or a CT scan. Those are the folks that we can do surgery with, the ones that usually are surprised that we find cancer. By the time they're symptomatic enough that we're pretty sure it's probably pancreatic, we don't have anything to offer in terms of curative treatment. Anything else?
Christine,
Oh, sorry.
if you're a survivor, does that mean you're technically still going through palliative care? Or does your palliative care stop when you become a survivor? Wouldn't it always be that you're being cared for? This pancreatic cancer will end in death even if you are cured of it? Or will most of these people die of other causes?
It depends. I mean, it just depends on how early you were diagnosed. I mean, they had somebody in this group that was 2 years out. I would consider it.
It also depends on the type of tumor. Like a neuroendocrine tumor, it's very slow-flowing, completely resectable, and you're never going to have to deal with that probably again once it's gone.
So survivors can continue to have palliative care.
I'm curious if any of them were struggling in the narrative about still wrestling with how they got it. Why me, and how did this happen? And were they searching for,
Yeah.
were they searching for answers? And
There was one.
Well,
Many of them, though, were very, this particular group seemed to have a very strong spiritual perspective, even though they came from all over the place. But there was one that really struggled with it. And then there were others that would just talk about, I know this happened to me for a reason. And that was as much explanation as they seemed to need.
providers, because we're all different types of kinds of healthcare providers, and we're gonna all touch patients in different ways, and particularly as we look more at trying to do interprofessional, interdisciplinary, collaborative care. We're using all these different new kinds of models, and we talk about, you know, the fact that the team and trying to, they see all these different people and trying to make sure that we're all on the same page. One of the things that in reading these transcripts that was interesting to me was there was one patient that talked about the chemotherapy nurse, the infusion nurse, and that infusion nurse, all she was worried about was talking to the patient about the side effects from the chemotherapy. And so she was just tunnel vision on, I need to talk to you about your chemo side effects, and didn't necessarily seem to get beyond focusing on the side effects for the chemo treatment. And that really bothered that patient. And so one of the quotes that Kathy read too was the fact that, you know, getting to know more about who I am as a patient. And I know I'm an old oncology nurse, that was always something that I know I tried really hard to do. I mean, you know, you learn and you do what you have to do to take care of them. But I think that's one thing that we learn about through these transcripts and continue to come through was you really have to make sure that you pay attention to the patient, who they are, and who their family is, and all. It really run through on these transcripts.
They're very frustrated at how, they talked about nurses, and of course that's because they're under nurses' care for the largest amount of time. But they talked about how frustrated they were that nurses didn't have time for them. And they recognized that it wasn't necessarily the nurse's fault, it's the fault of the system. They talked about all the documentation and the, you know, trying to coordinate all these different disciplines and things. And so we were commenting at how, you know, we need some administrators to sit here and read this to understand. Patients really get it. I mean, they really see what's happening. And the other thing was about how when they are going through that diagnosis and treatment in particular, they need to feel like it's all about them. And we have to learn how as healthcare providers, when we are juggling so much, they need us, right or wrong, they need us when we're in their presence for it to be all about them. And I thought that was very powerful.
One more thought. You had something about they wanted hope, right? And to me, I struggle with that, and knowing that the type of diagnosis is one, because you don't want to necessarily give this false hope, or at least to encourage. I remember a time when I would say something and it was totally misunderstood, so my nurse said it's going to be okay. How would you be able to provide them with that hope, but still being very realistic about what's going on with them, so as not to get them confused?
Well, I think it's like when they kept, you know how they kept talking about, I want the facts and I want the truth. And I think then you have to read where they are in receiving it. So if they're still in that hoping for a cure, then you appreciate that's where they are, even if you know that's not realistic. You appreciate where they are, and you continue to talk about, you know, so what have you understood, and what is your next step? And get them to sort of do that processing piece and be truthful. You know, if they ask you, do you think I'll be here in 5 years? You know, you have to decide, are they ready to hear the statistic about that? Or do they need to hear it's different for everyone? And that's where your experience and knowing that patient. Nancy? Interviews, there was one informant, he was a man, and he would not do anything except exactly what you asked. So the interviewer was having to ask lots of questions, trying to get him to open up and talk, and he was just everyone else, they went on for about an hour to an hour and a half. And again, the data collectors talked about how this was very therapeutic for them.
And was this at home?
It was both. Some of them wanting to do it where the support group happened, and so they came early or stayed late. Many of them, though, really wanted the data collectors, and remember, they were graduate students in nursing. They wanted them to come to their homes, and so they went and sat down, in their home and did it. So we gave them the choice of where they wanted to go.
Two questions. How many questions did you start off with? Did you like a set interview piece?
Those core questions that you saw, those were pretty much the set. Although usually they would just start off by saying, tell me a little bit about yourself and your diagnosis to get them focused and then start the quiz.
And then did you see anything with alcohol not a risk factor?